The following presentation was recorded at the 2017 ANZICS Safety and Quality Conference.
Hi, I'm Ruth. I work at our Wellington Hospital, which is a tertiary centre that covers central New Zealand. I work as a PAR nurse, which is a 24/7 service. It's a nurse-led team. It's similar to the nurse liaison service that you have here in Australia. We review deteriorating patients, attend MET calls and review ICU discharges. So just to put this talk in context, at Wellington Hospital we don't have goals of care for any patients. Our only formal treatment limits is a DNR order. We attend approximately 1,500 MET calls a year. And the focus of this talk is how the MET team manage unidentified end-of-life or treatment limits at MET calls, and a form that I've developed to improve clarity towards staff and to assure appropriate interventions for patients. So the aim of the project was to develop a process for managing newly identified end-of-life or treatment limits at MET. So where the primary team haven't identified goals of care or an end-of-life event, and the MET team has had to meet this requirement. But I've observed many situations where patient requests and outcomes haven't actually been discussed at a MET call, and where a patient's gone on to have advanced or invasive treatment when it hasn't necessarily been what they've wanted. It was also to ensure that patients receive appropriate treatment in the right place. So not all patients benefit from intensive care or advanced therapies, and it was to ensure that patients receive appropriate treatment for them in the facilities that we have at Wellington Hospital, and to provide clarity to nurses regarding escalation pathways. So there's a wide gap of treatment between a DNR order and a treatment and full treatment, and nurses can be left confused with this huge grey area that's unclear, particularly when early warning scores are modified to cover a deterioration and there's no escalation plan. Excuse me, too nervous. Right. So, as we all know, the medical emergency team was designed to stabilise patients on the ward, implement advanced care and prevent cardiac arrest. And in that process we've discovered that 1/3 of MET calls result in treatment limits. Probably at Wellington Hospital it's more like a fifth, but we still manage a significant amount of treatment limits. And this is because on the way to death, early warning score activation occurs. You can't die without passing through the MET criteria. And this is because there's a lack of discussion prior to these deteriorations from primary teams. So the MET team work 24/7 and end up having to make goals of care or provide treatment limits on patients where the primary team have failed to do that in the office hours in which they work. So the MET team has to do this often out of hours when they've only met the patient briefly in an acute situation, and often without senior specialist help. So this is occurring because we're increasingly managing and looking after older and more frail patients with extensive comorbidities. In New Zealand, by 2030, 1 in 4 people will be over the age of 65. And our nursing care is very complex for these patients now. There's an adequate planning for end of life, and there's an adequate recognition of the dying patient. There's quite often a single organ focus, so a patient comes in with an acute organ issue which is managed by the team, but the big picture is not reviewed. And this was reflected with Mrs. B, who was a frail rest home patient who'd fallen out of bed, had a fractured neck of femur, and had a repair done, and overnight she had 3 MET calls for hypotension, but at no time did anybody discuss a treatment limit or DNR for her. So despite triggering 3 MET calls, the MET team did not alter her plan of care at all. And it was in the morning when she was about to trigger the 4th MET call that it was reviewed as to what was the appropriate care for her. So in some cases, in prolonging life, teams are actually prolonging death. So to clarify if there was a need to improve the communication at Met Calls. A survey was conducted at Wellington Hospital. So people who had been involved in a Met Call in the last year were asked to respond. So we've got 100 responses, and the majority was nursing, 83% was nursing, and in the month prior, 75% had actually been involved in a Met Call which had resulted in treatment limits. So in the findings, 51% found that the documentation was actually really difficult to find in the notes. So unlike a DNR form, which is placed in the front of the notes and easy to find, what people were writing was actually lost in the body of the notes. It was just a handwritten entry. It wasn't clear and it wasn't in the front of the notes. 41% felt that a treatment limit at a Met Call was not actually put in place when it should have been, and 86% were happy to have formal documentation. So these were a couple of the comments. So the patient's clearly dying, but the primary team want full active treatment despite ICU not accepting the patient. And I'm sure we've all had scenarios like that, but it's very confusing for nurses to manage these patients when they have somebody who's got significantly modified early warning scores, or they're unconscious, but they're still having to actually provide active treatment and frequent OBS and interventions. And another comment, sometimes early warning scores are changed to stop a Met Call being triggered again. However, the patient's still extremely unstable and the issue's not necessarily addressed. So, I mean, I've seen people with early warning scores of 15, but no plan and no escalation. And I don't know if this happens in your hospitals, but this comment, just one moment, was the patient's not for CPR but for DC shocks. They went into a VF arrest. They were 84, frail with many comorbidities. They got 4 shocks before passing away. His wife was present, and I felt like the CPR versus the shocks was not discussed. If he had not been for CPR, he should not have been for shocks either. It's a traumatic way to die in front of his wife. So this was whether verbal and documented treatment limits at the Met Calls were actually easy to understand. And as you can see, actually it wasn't that good. 38% of documented treatment limits was easy to understand and 45% of verbal. So there was a huge room for improvement and clarity in documentation following Met Calls. So I'm not going to go into this, but this was just the process that I went through to develop the form. So it was done in consultation with the clinical leads of the hospital, with medical, palliative care and surgery, the director of nursing, and the form was developed and it was trialled on 3 wards for a month before it was actually implemented hospital-wide at Met Calls. This is just a portion of the form. Now this form is based on goals of care, but it's different in that it does not address anybody that is entitled to full active treatment. This only applies to patients who have a treatment limit at a Met Call. So they need to have a DNR form as well. So this form is provided by the PAR nurse, so we carry this form with us and we provide it at a Met Call. It's specific to Wellington Hospital and the facilities that we have, and it must be completed by the medical team of the Met, but also in conjunction with the patient, the family if they're there, and the primary team. It may not always be the primary team consultant, it may actually be the reg, and normally the ICU consultant is also consulted over it. So it is a challenge to complete this form, particularly out of hours, but it does clarify a basic escalation pathway for patients and gets reviewed on the ward round by the primary team. So there's 4 options here. The first option is patients who go to ICU but with limited intervention, so it's like the HDU patients. Our second option is for patients that go to high dependency care and would get non-invasive. The third option is for patients who get ward level care, and at that point you determine whether they're for a Met Call or not. And the fourth option is for patients who are at end of life and get symptom relief, and the aim is to provide dignity in their death. So in conclusion, there is a lack of recognition of identifying dying patients, and this is just a small step in identifying patient goals of care for this limited cohort. It's only for patients that have Met Calls. There's significant limitations to the form, but it does provide clarity to nurses regarding treatment limits at met calls, and it aims to provide appropriate care to patients in dignity and death. The form has been used for 8 months and is still to be audited, and the future for our hospital requires addressing advanced care planning and goals of care for all patients. Thank you.